Hi, Montreal. I am here with Dr. Nadia Gianetti. She is head chief of cardiology at the MUHC.
That's correct, yes.
You've been in practice for 20 years.
That's correct.
And
yes.
You're going to be honored at the Bal Rouge.
I am.
That's coming up on April 5th.
April 3rd.
April 3rd. Don't go
Okay.
April 5th, come April 3rd. I just didn't want anybody to come and I was going to be alone. Interview you there. Okay, so tell me, what have you seen over the last 20 years, like in terms of heart? You do heart transplants in your department, you
That's
do all
right.
kinds of mechanical hearts and so on. What have you seen?
So it's been fantastic. Cardiology has evolved so much in the last 20 years. I think most importantly, there are things that required open heart surgery 20, 30 years ago with big cut across the chest, open up the chest, take the heart. The surgeons would have to take the heart in their hands and fix valves or bypass arteries. We're doing a lot more now, what we call non-invasively. That means with catheters. So patients will get catheter in the arm or catheter in the leg. They can open up the arteries a lot more than they used to. Smaller arteries, more complicated blockages, and replace valves. And that's very exciting. If we look in the last 10 years, we're doing a lot of valve replacements literally through the groin, through the leg, without any
Breaking
opening,
the ribs
without
and all
opening the ribs, and patients can go home the following day. It used to be the aortic valve, now it's the mitral valve, and we're moving into the tricuspid valve. So really now, 3 out of the 4 valves of the heart can be done with catheters.
And is
So
the
that's-
valve where the heart disease attacks? Is that the weakest
so,
point?
So, when you look at heart disease, it can attack the heart muscle. That would cause heart failure. It can attack the arteries. So that's the coronary artery disease. That would cause heart attacks. It can attack the electrical system. And it can attack the valves, which are the doors that open and close that permitting the blood to go forward and preventing it from coming backwards. So any of those areas can be attacked. Also, great evolution in what we call electrophysiology, which is the electricity in the heart. Patients who have arrhythmias, the heart goes too fast, the heart beats irregularly. Now with catheters in our electrophysiology lab, all of those can be regulated.
Okay.
So very exciting as well. So there's been tremendous change in the last 20 years.
And so people are living longer with heart disease.
Absolutely.
Okay.
People who had, historically, patients who had a very large heart attack could not live out that, after that heart attack if they made it to hospital. Now people come in, once they make it in the hospital, because remember, not everyone with a heart attack actually makes it to hospital. Some people will die at home. But our patients who make it to the hospital, we have a lot that we can offer them to keep them alive. Sometimes it's putting in what we call cardiac support devices, a type of mechanical hearts that we put in. Some are temporary, just to get them through the difficult period, and some are more long-term.
Okay, so my next question was, how do we hear all kinds of things out there on how to prevent heart disease, and there's don't eat this, don't eat that.
Yeah.
You're the source, you're the boss. If you were going to tell me and I don't have heart disease today, what would you tell me to do to help prevent that?
I would tell you that everything in moderation, first of all. Okay, so with respect to diet, it is quite controversial. Okay. It depends a little bit on the individual. Some people are more prone, some people are less prone, because we all have our own intrinsic cholesterol kind of metabolism that occurs, okay? But generally speaking, more fish, less red meat, two red meat portions a week, more fish, which has the antioxidant property, reduce the stress. That high adrenaline, reduce the stress.
Really? Is she talking to me?
Yeah, exactly.
I'm going to tell you right back at you. Yeah, I'm sure you're not exactly walking.
Exercise, though, yes. Exercise. 30 minutes a day, at least 5 days a week.
Okay.
No smoking. 0. No vaping, no smoking.
No weed.
It's a good question. That's a little bit more controversial. We don't really have any great data, but, certainly we'd keep it to a minimum. Okay. The inhaling is probably more the problem than the actual THC.
So taking it in a capsule might be better off.
The inhaling is probably more of an issue. Keep the blood pressure under control. Watch the blood pressure. Historically, we tolerated higher blood pressures. Now we're saying keep it lower. So make sure your blood pressure gets checked. Okay. Make sure you have a family doctor. That's a very important thing. Make sure your sugars get checked. Prevent that diabetes. So keep the weight off. So there's a lot of things that can be done to prevent heart disease.
Okay.
And know your risks. if somebody has a family member that had a heart attack at age 50 or 60, there could be some genetic predisposition for heart disease, and you would want to know that. So it's important to know your risks.
Okay, so know your family, eat properly, exercise, and keep the stress low, and stop smoking.
That's right.
There's a few of those on my list. I got to
There you go.
Talk to me. Most interesting thing I've heard you say right now is the mechanical heart. Talk to me about that.
So mechanical heart is it's a bit of a misnomer. We call it a mechanical heart, is sort of a lay term, but it's really what we call a ventricular assist device, VAD. And what that means is that the heart stays in place, but a pump is attached, and that's our surgeons in this hospital, Dr. Chicheri will do that. He'll attach a pump to the heart, and the pump rotates the blood and pushes it out. So it does the work of the heart. Your heart's still there, but the pump does the work of the heart. And patients will go home with this. And we have patients who are home with this for 2, 3, 4, 5 years. Some patients are on these as they wait for transplant.
Will it improve to the point where we can replace the whole transplant situation with these hearts?
This is what we're hoping for. Right now, the technology necessitates a little wire to come out of the body, and the patients have a little controller and batteries that are attached. Okay. So it is a little bit cumbersome. It is evolving as the technology of the batteries evolves. As an example,
I guess
they'll be much smaller batteries. Eventually, we're told by industry that they're going to not require the driveline to come out anymore. So it is evolving. Is it going to replace transplant? It is certainly going to be a very close contender to transplant, I would say, in the next 5 to 10 years.
Oh, that's beautiful news.
So unfortunately, it's not for everybody. It's for the majority of the type of patient we transplant. Some people have different cardiac conditions, so it's not going to completely replace transplant. But in some people, it will be a close second contender.
Is getting a transplant in Montreal and Quebec much like you see on TV? You get on a list and you wait, and you unfortunately wait for somebody to have an accident.
That's right.
That's how this works.
Yep. So what we do is we evaluate people who have what's called end-stage heart disease, that there's no other options. People who are living a very poor quality of life. Sometimes we see that the kidneys or the liver are starting to suffer because of the heart. And we put them on a list, and it's a very difficult wait time for patients while they wait on the list. Some wait 1 year, some wait 2, 3, 4 years. It has to do with your blood group. It has to do with your antibodies in your blood. It has to be with your size.
Size of your body versus the size of the heart has to match.
That's right. The size, your weight. You need to have a donor that is a similar weight, to the recipient. And so there's a lot of factors that come into consideration. For some people, it's a very, very long wait, a very difficult wait. So sometimes what we have to do is we have to implant these left ventricular assist devices in patients as they wait for the transplant.
At least there's something.
That's correct.
And I'm sure that when you started, that wasn't there.
That was not the case.
Okay.
And certainly the ventricular assist devices, the old ones, even from 10 years ago, could not last, as long as we wanted them. They had about a 12 to 18 month duration, so that was an issue.
And now
they can, the last one we did, we had a patient that we transplanted in the fall who had a ventricular assist device for 5 years, and then we found him the perfect heart, and he's doing really well right now.
That's beautiful.
Yeah, so it's
great
fantastic.
Things. Is it like on TV when people put the defibrillator on you, and does it really shock you? Everybody has to stand away, the whole thing?
Yes.
And is it painful for the patient?
Well, what we do is that, we use that in situations where patients who have something called atrial fibrillation. What we'll do is it's in a very elective kind of situation. We'll put him or her to sleep, and they will get the shock, and then they will wake up. So that's one scenario. They're put to sleep, so they don't feel it. The other scenario when we do that is when somebody has what we call a cardiac arrest.
So they're already kind of gone.
They're basically gone, right? And
so you're bringing them back.
You're breaking them back. So in theory, they're not supposed to feel it.
And does the body move that way?
It does.
And everything.
It does shake, and it is. It's when you're putting the paddles and you're pressing on, you do feel kind of that pushback. It is.
Okay.
It is quite something. Yeah.
Okay.
Unfortunately, that's something that we have to do. And in an institution like this, we have what's something called a code blue team.
Right.
And code blue is when there's a patient in the hospital that it can be a patient, or it could be a family member. It could be at work, or it could be anybody. that
There's one in the
collapses,
hospital.
and the team goes to attend to that person, and if the heart's not beating and they don't have a blood pressure, then these are there's an algorithm that we follow, but the shock is a very important part of that algorithm. So that is a real thing. That is done,
So
on a
not just
regular
on
basis. not just on Grey's Anatomy.
Not just on Grey's. Okay. Okay. Upcoming, we have the Bal Rouge. We said
Yes.
it's on April 3rd. Dennis Carranza will be speaking
That's
at this
correct.
event. He is a recipient of a heart.
That is
And
correct.
for 2 to 3 years, he's had an official heart transplant,
That's
and he's
correct.
surviving. It's 2 to 3 years
Absolutely.
later. He will be speaking at the event.
And he's somebody who lived for about 3 years on a ventricular assist device at home. He was very, very sick and could not leave the hospital unless he had a ventricular assist device, which he did with a great, great attitude, great morale, got through all of that, and now he's living beautifully with a heart transplant, a perfectly, excellent quality of life.
Did he, when he had the mechanical heart,
Yeah.
the VAD?
Yeah.
Look at me. Can
Yeah,
I take your
you're
job?
very
I'm gonna
quick.
take your job now. The VAD, was he able to function, go to the gym,
Absolutely.
or is it
No,
mild?
he did really well with that.
Okay,
Yeah,
beautiful.
absolutely. No, he was with the VAD, had a good quality of life, but always tethered to
Right.
machines.
You're
So
not
the
free,
transplant-
but you have a much
That's right.
better quality
Yeah.
of life.
Absolutely.
You can go back to work, in other
That's
words.
correct.
Okay,
Yes,
so that's
absolutely.
good. All right, I'm
Yes.
looking forward to hearing from
Yes.
him at the event. We will see you. You're being
Yes.
honored at the Bal Rouge
I
this
am,
year
yes.
on April 3rd, so we'd look forward to seeing you there. You can get tickets at the MUHC.com, and or you can just tag this post and ask the questions of the MUHC staff.
Thank you so
Thank
much.
you.
Thank
Have
you.
a great
I
one.
appreciate it.
See you then.
Thank you.